Hello and welcome to week 5 of HCA 528 Health Policy. This week this will be a relatively short session here. I'm going to be talking about some items of payment reform, and the lead into this will actually be a YouTube video done by a gentleman named Harold Miller, who is an expert on the topic and who can provide a great deal of information in this area. So our agenda for today we'll have a brief discussion of payment reform, some of the initiatives that have been taking place in that area, and why that's important. And then there'll be the segue into the Harold Miller. It's essentially a TED talk he did on the subject a few years ago, and then the weekly discussion. So let's talk a little bit about payment reform and why that's an important thing. So here, there are a number of commonly used payment systems within healthcare. We have fee-for-service, we have tiering, we have accountable care organizations, and patient-centered medical homes. So we'll talk a little bit about each one of those. Fee-for-service, it is still the backbone of the system. It is still the most commonly used part of the system. And what is fee-for-service? It's essentially exactly what it sounds like. You provide a service, you get paid a fee for it. And that is, so fees are paid separately for whether it be procedures, doctor's visits, medications, any other services. They're all paid for separately. And this is very common, especially in the outpatient setting. Even within hospital settings, it's done in a similar way, just using a different form. So those are, and that is still the most commonly used system today. So what is the problem with fee-for-service? Well, the bottom line is with fee-for-service is that all the incentives are upside down. So there is no incentive to keep a patient well within the system. So the more doctors and providers do, the more they get paid. So in this scenario, a sick patient is actually worth more to a hospital or a healthcare provider, or they can be worth more to a hospital or provider than a healthy patient is. So the results include care that is uncoordinated, certain services can be duplicated, and you can have fragmentation in the system. So now let's talk a little bit about some other means. One is called tiering. So this is more of the relationship between the patient and the health insurer. So in this situation, it is used as a tool to help patients manage their healthcare costs, and insurance company for group providers by various tiers. So you may have 2 levels of tiers, you may have 3 levels of tiers, other types of levels. So such an example of this could be a provider that is preferred, that is in the preferred network, is either in network or out of network. And essentially what happens here is that coinsurance rates are much higher for in network as opposed to out of network in terms of what the insurance company will pay. So an example of this is a preferred provider might charge a 10% coinsurance, and an in-network provider might charge a 20% coinsurance, and an out-of-network provider would be an 80% coinsurance. So that is essentially, so what the insurance company is trying to do is to direct their patients to the providers that they have the preferred relationship with. So this can now on the plus side, this is a way for patients to potentially get a better deal at various providers. On the downside, there are a couple of downsides here. First of all, it doesn't providers that are in network or out of network doesn't necessarily mean that they are of higher or lower quality. It is just a function of what financial arrangements the payer has made with different providers that allows them to be considered to be in network versus out of network. So just because a provider is in network doesn't mean that they're necessarily better. It's just that they're in network for that particular payer. The other thing that is a potential issue is that payers can be, if a payer is geographically focused, such as a local Blue Cross plan, and you work for a company that has that service, but you don't live in that area, say you're a remote employee, you may have a situation where all of your local providers are out of network because they aren't in proximity to that particular payer. I had a role myself last year where I was working for a company out of Maryland. They used a Blue Cross plan out of Maryland, and all my providers up here in New England were all out of network. So it made for very expensive healthcare, even if I was able to use that. So another common arrangement is called an accountable care organization. This is where you group providers across a variety of settings, such as primary care, specialty physicians, hospitals, clinics, these providers jointly share responsibility for care for quality and cost of care, and you provide coordinated care across these different types of providers in order to reduce redundancy and unnecessary tests and overlapping care. So how does this? So this is essentially moving from fee for service to fee for value. So you have targets given for various types of care, and if the costs come under that target, the ACO may get a bonus on that. If it comes in higher than the target, they may get a penalty for that, and that will depend on the type of payment arrangement the ACO has. So in that scenario, you may have a one-sided or a two-sided payment model. On the one-sided model, the payer has the bulk of the risk in the arrangement. So the provider will be getting a share of bonuses, but not necessarily penalties. In the two-sided model, the ACO shares savings and losses for the period of time within their own different contract, and they can choose these payment models based upon the degree of risk or savings that they're able to undertake. And then as far as how the patients are evaluated, there are a number of quality measures that are used to evaluate how well an ACO does. These are often referred to as star ratings. So ACOs are evaluated across patient caregiver experience, care coordination, patient safety, preventable health, and at-risk population care. So there are a variety of things being used to evaluate providers in this area. Another function of this is what is called bundled payment. So this is getting into what's called population health management. So you estimate the total cost of services a patient will receive for an episode in one of these categories. So you have a scenario where care around this particular area is kind of predictable. You may have a procedure and a certain degree of follow-ups that are associated with that, and so you have some degree of predictability in terms of how that care is going to be provided. So things such as knee and hip replacements are a common function for bundle payments. Some heart surgeries are actually common functions for various bundle payments and the like. So here's an example for bundle payments. You might have a knee replacement. So you might have a 30-day bundle for a knee replacement of $10,000. But what they do is they reduce the cost by 2%, so that's $200 off. So the new payment that they get is $9,800. If the provider is able to come in under that $9,800, they'll reap the difference of that. If they go over the $9,800, there'll be a penalty for that. So this encourages providers and hospitals to work together to accomplish this goal of providing the same care for fewer resources. Another component is called a patient-centered medical home. So this is funding a coordinated team of primary care professionals who will be providing patient care across the spectrum. So it could be a combination of physicians, nurse practitioners, medical assistants, nutritionists, psychologists, social workers, and the like. And these folks work together to build a strong relationship with their patients and their caregivers. So that is a very, very quick summary of some of these items around payment reform. And I would encourage you to watch this YouTube video by Harold Miller. He and I have worked together in the past when I was working at a role at the Jewish Healthcare Foundation in Pittsburgh. He is an expert on this area. He has a very interesting TED Talk here that will describe these functions, and I encourage you to take a watch of that. And then finally, for this week's discussion. Pardon me. I want you to discuss these alternate payment models and how they could improve the healthcare system and any potential pitfalls that you see within any of these approaches. So I look forward to your responses on that and to reading what you have to write. And I'm hoping that the groups are hard at work by now in terms of getting your group projects ready. I have gone through your submissions on the draft for the individual papers. Those are all looking quite solid, and I look forward to seeing what you have to write in the discussions and any other help that can be provided. So thanks very much.